So maybe we'll just get started. I want to welcome everyone. We are very excited to be kicking off the first in a new data literacy series. We had almost 270 people register for today's event, and I know once you've had a chance to share how exciting it was, that our numbers will increase exponentially. I would like to introduce and thank our speakers for today. We have Derek Chechak, who is the Director of Quality Improvement and Crisis Services at St. Leonard's Community Services in Brantford, Ontario. He has extensive experience in social work and mental health and has contributed significantly to the field through research, teaching, and management roles. He has a strong focus on evidence-based implementation science and evaluation and driving clinical and operational excellence in mental health and addictions. Notably, he has published on various critical topics, including workplace health, workplace violence, and the opioid crisis in Canada. Dr. Chechak is a registered social worker and a valued member of the Ontario College of Social Workers and Social Service Workers Standard of Practice Committee. And also welcoming Aaron Carubba, who is the Quality Assurance and Data Management Lead at Wayside House of Hamilton. Aaron applies a background in experimental biology to residential treatment through rigorous data-driven studies of the client experience. The objective of today's webinar is to provide our participants with a clear understanding of data literacy and why it's important for mental health and addictions providers and the sector more broadly, including areas around data literacy, data quality, basic data concepts, data collection, data management, and visualization. And as the title of this webinar suggests, we will share our experiences of the power of data and hopefully help you use your own superpowers. We also want to know from you what you would like to learn today, and so there will be an opportunity partway through the presentation to do a poll to tell us which topics you'd like us to cover. And so we'll just get started now with a land acknowledgement. Today I'd like to share my land acknowledgement with you. Land acknowledgements are imperfect, and they encourage us to learn about the land where we reside and to consider the impact we have on Indigenous people. It also creates an opportunity to reflect on how we can make changes that can improve our relationships and the experiences and outcomes of First Nations, Inuit, and Métis people in Ontario. I'd like to acknowledge the land on which I am gathered right now, which is at the CMHA Ontario offices, as the traditional territory of the Métis people and the Wendat, Chippewa, Anishinaabe, Haudenosaunee, and the Mississaugas of the Credit First Nation. This territory is part of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Confederacy of the Ojibwa and Allied Nations to peaceably share and care for the resources around the Great Lakes. These agreements are intended to reflect a shared commitment to being stewards of the land and thus the image of the dish with one spoon. I acknowledge that colonization and racism continue to influence social structures such as drug laws, the legal system, child welfare, housing, and healthcare, including mental health and addiction services, and this leads to disproportionate harms for Indigenous people. I also want to share that I am grateful for the information and the support that I've benefited from people who have had to find the patience to educate me. In terms of situating myself, I'm a settler in Canada. My parents moved here with me from India in the hopes of building a better life for our family. I've been fortunate to be able to call Canada my home now for over 50 years. Through reading and talking to people, I'm committed to increasing my knowledge and awareness of the true history of Canada and ensuring that my work and interactions can reflect my learning. Today, Ontario is still home to many First Nations, Inuit, and Métis people from across Turtle Island, and I'm grateful to have the opportunity to work on this land. I also recognize that many of you are attending from other territories because this meeting is being delivered virtually, and that you're on parcels of land for which this land acknowledgement does not apply. And I hope that you have an opportunity to learn about the lands where you live and work. I'm also realizing that I have not taken an opportunity to introduce myself. I'm Noshba Degani. I am at CMHA Ontario. I am the Chief of Quality and System Performance, and I am a co-lead for the Excellence Through Quality Improvement Project. So now to turn to our webinar. Why are we doing Data 101? Part of it is really just recognizing that there's a need in our sector for more data literacy. Where are we now? Our sector is made up of agencies that range in size and service delivery. There's variation in the infrastructures that we each have, and the IT, digital, and data collection supports that we're able to marshal, as well as the quality improvement resources that we have. Right now, in the mental health and addictions sector, there are no mandated data collection tools. We do have a tool within the addiction sector that's a required tool, but it is still not consistently implemented. As a result of this, agencies are often using their own data collection instruments, which means we don't have consistent ways to assess provincial performance or local performance for the purpose of accountability, public reporting, or comparisons. And agencies don't have reliable comparators when they're trying to understand their own performance or their opportunities for improvement. I also want to acknowledge that decision support, data analytics, and quality improvement are often not core functions of community mental health and addictions agencies, which means it's often described as side of the desk work. Now, where do we want to be? So we want to be in a situation, I acknowledge this is where we want to be from my perspective. And I encourage you to share your own goals for your organization and our sector in the chat as I discuss what I think are the goals of our sector. So we want to be at a point where data are being collected once and used multiple times for different types of reporting rather than us having to submit multiple reports. We want to also make sure that the data that we're collecting are primarily being used to deliver care and to measure client outcomes so that the data that so that we see the value of the data in delivering services. We also want to be able to use our data to identify gaps in care and to guide quality improvement. We want performance measures that are valid and reliable and that measure important outcomes and processes. And Derek's going to talk more about this in his section. And we want performance measures that we can compare over time and across the system. Performance should be able to be benchmarked either based on evidence or based on the performance of other organizations. When we talk about measurement, sorry, I'm trying to advance the slides at the same time. So when we talk about different types of measurement, there's also measurement that can be at the point of care, which is useful for clinical decision making, for client engagement, for understanding client experience, and for quality improvement, and for organizational accountability. There's also organizational measurement, which can be used for data-driven decision making and planning, and can be used for performance management and monitoring. Also, still for quality improvement and for transparency. And then there's measurement at the system level, which can be used for public reporting, accountability indicators such as what you'd find in your accountability agreements, and again, also still for performance management and performance monitoring. So where do we want to be? We want to be somewhere where we have an organized system that is intentional and rational with little to no redundancy and lots of transparency and efficiency. This may seem like a dream and even almost after, and something that is really difficult to attain, but even after 30 years in health system performance, I really believe we can accomplish this. And I believe we can accomplish this by really putting clients at the center of the work we're doing and understanding their needs, and then building out a system that is focused on the quadruple aim and the quintuple aim to ensure equity, effective services, good outcomes for clients, good experience for clients, provider experience, and value for money. Where we don't want to be is a place where what we have is a lot of different measures that we're collecting with very little understanding of what the measures are or how they should be used. As this graphic describes, with indicators and measures that no one understands, and with declining performance and declining use of the data. I'm going to shift gears a little bit and talk, oh, sorry, and I've gone too fast. So I want to talk about something that we've been working on at E-QIP, We've been trying to develop what some of you may have seen something similar to this, that is a quality improvement graphic that shows a dose response relationship between different areas of it. The quality improvement one is focused on quality improvement. This is focused on data literacy topics and different roles. And so what you can see from this is that what should be clear is that for every organization, you need data expertise to be able to, and a high level of data expertise to be able to do the work that we're doing, and to, as we move into a more data-driven environment, and that everyone within an organization needs some amount of data literacy. I think we're now going to launch a poll where we're going to ask you, sorry, we also recognize that the roles that we have here are not necessarily roles that are reflected in every organization, and that in many cases, some of these roles are going to be done, there are going to be multiple roles done by one person, and in some cases, almost all the roles done by one person, especially among smaller organizations. And so we really do want to understand from you who's represented in the room today, what your organizations look like, but also what you'd like to see as topics for future webinars within this series. So I think, Naveen, I'm going to ask you to launch the poll. And we'll give it a minute or two so people can identify which, especially the data literacy topics. We do want to make sure that we're building out a webinar series that's going to be valuable for you and for your colleagues, so that what we have is a resource that you can use. We'll just wait one more minute for the poll to be completed, and then we'll share the results. And Naveen, can you share the results?
Yep, no, Shubha, do you want to give it maybe 20 seconds more? They're still coming in.
Yep, sure. Okay, so we can see we have a lot of people. We have 17% that are senior management. We have 7% who are directors of quality and analytics. We have clinical staff. We have middle management. We have a small amount of frontline staff. We have almost 15% that are decision support. We have folks from quality improvement and from IT. And then when we talk about what topics you want to see, it's great to see the high level of the interest in almost all the topics, with most topics being over 40%. I see that there's not as much interest in data privacy and ethics. Thank you for that information. We'll make sure that we only touch on that very briefly. And data cleaning and pre-processing. Oh, that's an area that I think is really important, but we will make sure we're reflecting your wishes. Data collection methods is really high, data quality assessment, data reporting and visualization, data-driven decision making. So I think I think that we can definitely build a series that will cover these topics, and we'll do our best to make sure that we give you the depth that you need. And I will take the poll down and go to the next slide. So as I said, the purpose of the webinar series is really to help increase the understanding of data and data literacy, and to advance the ability to analyze and use data to improve planning and delivery of mental health and addiction services. In today's webinar, we're going to learn some early building blocks around data literacy, and we're going to learn about the experience from a practical perspective that demonstrates the value of data in elevating service delivery. One thing I want to say just before I turn the slides over is that as a reminder, data literacy and data-driven decision making, it's not math. So Please don't worry if I always hear, oh, numbers, it's hurting my head. I wasn't very good at math. This is not math. What we're talking about is understanding your data. And I promise you, you're all already doing data-driven decision making. If you looked at the weather and made a decision about what to wear today, that's data-driven decision making. And so to just keep it as simple as possible to make things relevant for you, we really want to make sure that we give you something that you can use to improve the way services are delivered. Oh, and Laura's reminded me, I forgot to note that if you have questions, please type them into the Q&A function at the bottom of the screen. If you have comments that you'd like to share, please add them into the chat. If you put questions into the chat, we will move them over, but just we want to make sure we don't miss any of your questions. And finally, we also want you to know you're not alone through all of this. We have, through E-QIP, we have available to you quality improvement and data consultations. So if you have questions after this webinar at any point, please feel free to reach out to request a data consultation at quality@equip.ca, and we can do our best to provide you support. So with that, I'm going to turn it over to our first presenter, Dr. Derek Chechak.
Thank you, Noshiba, and good morning, everyone. It's nice to be reprising a bit of a data literacy series that we participated in a few years ago. The underlying theme of the material I'm going to present is that data literacy is increasingly pivotal in an evolving digital landscape. So in the information era where it's easy to find and often be overwhelmed by the amount of data and data sources, understanding how to navigate, interpret, and use information is not just a skill, but a necessity. So think of data literacy as a critical skill and also a language to communicate with. And as more people and organizations use different types of data to communicate, understanding the basic concepts becomes increasingly important. So data informs local and regional planning, system efficiency, and measurement-based care. There's recent examples in our sector, including the 2019 Digital Health Playbook for Ontario health teams. Health service providers also have access to volumes of clinical data that need to be interpreted, shared, and reported. Clients will have access, if they don't already, to their own health information and results, and they will need to be able to interpret them. Virtual care platforms, shared electronic health records, the Ontario Mental Health and Addictions Provincial Data Set, health insurance claim data, and I'm not even talking about artificial intelligence today. These are all examples of healthcare innovations that require data literacy. So the increasing focus on progress and outcome monitoring or measurement-based care requires data to demonstrate progress in implementation and health outcomes. These approaches require that client information is collected at routine intervals to inform changes to their treatment, and it's simply not enough to count visits. We're building a culture, and in a culture that embraces quality improvement and accountability, data are used to monitor performance, track changes before and after an intervention is implemented, and are transparently shared with boards of directors, funders, and even the public. Data literacy skills allow us to create outputs from these data, but also understand outputs created by others and understand what they're telling us. It helps us understand where data originated, how it was collected, and how it was analyzed and visualized. Data is power, but so is your ability to understand it. So I'm going to discuss a couple fundamental concepts related to data literacy to get us started. And I hope to convey the importance of understanding data, discovering and collecting data, and then supporting an environment that fosters the use of data. So how do we define data literacy? Well, like any term, several definitions exist, but one that I've been relying on for several years was developed in a 2015 report produced by Dalhousie University. These authors define data literacy as the ability to collect, manage, evaluate, and apply data in a critical manner. This definition includes 4 key aspects that we'll look at individually. Component 1, collection. There is an expression that's been attributed to a few different sources, which says that which is measured improves. So this is not to suggest that measuring something automatically leads to improvement, but it underscores that the right data must be collected in order to measure whatever it is you are interested in. Measurement is a distinct competency, but we must acknowledge the importance of data collection as the first component of data literacy. Collecting data doesn't always mean you need to start collecting new data. You might already be collecting it. What's important is that you're collecting information in a routine and organized manner. To get started with even the most ambitious plans for data analysis down the road, data must be findable and usable. If it's not effectively managed from the point of collection, it becomes progressively more expensive to find and manage when you need it. You might already be collecting data that you can use. Here are some examples of data that might exist within an organization and how it can be used for quality improvement, measurement-based care, or reporting. In our sector, accountability agreements make some of these decisions about what you need to measure for you. These agreements include specific targets, items, reporting frequencies and due dates, reporting standards, and platforms that you might need to submit to. So this information, especially when it's considered historically over a number of quarters or years even, can provide important insights and can be used for forecasting client volumes, human resource allocations, and maybe even revenues and expenses. Then there's sector-specific indicators, especially when they're paired with another data source or validated by another data source, such as stakeholder feedback. These can be used to identify potential quality improvement opportunities. A common example is looking at the readmission rate for clients who are recently discharged from a service, improving client experience scores that are captured through client experience surveys, and reducing the wait time between a referral being received and service being initiated. Stakeholder feedback is a broad category that can be a rich data source for quality improvement opportunities. An organization's board of directors, senior executives, staff, clients, families, and caregivers, and community partners can provide important insights into what aspects of your operations are working well and what can be improved. In a past regional project, I used a tool called the Wilder Collaboration Factors Inventory to evaluate leaders' perceptions of their collaborative working relationships with each other. Within an organization, employee experience surveys contain critical insights about day-to-day functioning and are aligned with the quintuple aim framework. Even social media posts can be used to gauge public opinion as a form of community feedback. Now, I'm not implying that individual comments are representative of an experience or a population, but they may point towards something worthy of further exploration. Standardized tools represent an important source of data because they serve a specific clinical or reporting purpose. They may already provide a database that stores the collected data for you, and in some cases, performs some of the analysis and visualization. With the growing and rightful emphasis on promoting equitable health experiences, client demographic information and community census data can both provide important information for an organization about the population it serves. Examining any differences in client experience according to socio-demographic variables is an important first step towards learning about unconscious bias and other root causes of disparities in health outcomes. So these are just a few of ideas where you might already be collecting usable data within your organization. The data you're collecting, excuse me, or planning to collect can then be used to identify indicators. First and foremost, when selecting indicators, it's essential to consider what matters most to our clients, to staff. These perspectives provide valuable insights that can shape indicators aligned with the goals and values of your organization. Ideally, we want to measure precisely what we plan to measure, ensuring that our indicators are valid. However, in the real world, we make compromises sometimes. We use existing data, even if it's not perfect, because it's a great way of getting started, and it still has a practical approach. For quality improvement initiatives, we should aim for reliability in our measurement, but sometimes ease of calculation takes precedence over the ability to make peer comparisons. The goal is to ensure that data we collect is not only accurate, but also reliable over time. The bullseye analogy illustrates this concept. You think of the center of the target as the concept you're trying to measure. Imagine that each time you attempt to measure the concept, you take a shot at the target. If you measure it perfectly, you hit the center, and if you don't, you miss. Something that's reliable but not valid means you're consistently testing the same thing over and over again, but it's not what you actually want to test. Valid but not reliable means that in the end, your average result will probably align with what you're measuring, but the individual scores are not consistent. And if a measurement is valuable and reliable, it means it's consistently going to measure what it's supposed to over a period of time. It consistently hits the bullseye. Indicators should always point in a clear direction for improvement. Each indicator chosen should have a purpose and contribute to the overarching goal of enhancing service quality. Timeliness is key. Data need to be current to facilitate informed decision-making. Outdated information can hinder our ability to respond promptly to emerging trends and challenges. Indicators should be actionable. They should provide a basis for tangible steps toward improvement. If the data collected cannot guide actionable strategies, you may need to reconsider if it's necessary. Selecting indicators is a thoughtful process that involves understanding the perspectives of clients and staff, ensuring validity in measurement, prioritizing quality improvement, maintaining a clear direction for improvement, insisting on timely data, and ensuring that indicators are not just measurable, but also actionable. Once you've established your indicators and the sources of data that feed into those indicators, you'll need to set some parameters around the data collection itself. So from the outset, it's crucial to define clear objectives, ensuring that the data aligns with the overarching goals. Strong data collection practices is often an early step in what we call the data journey. The purpose is to determine what data you need to answer the question you're looking to answer. You'll want to identify what the target population is. This could be clients, family members, or loved ones, or agency staff. You'll want to determine the unit observation, what items you will observe, measure, or collect when you're trying to learn about your target population. Is it individuals, groups, families, employees, communities? This could be administrative data, client experience data, or financial information. And then you're defining the time frame because you want to know if the data you need is recent enough for what you're trying to understand. Once you figure this out, go back to the data sources and determine if they can meet your needs. Can you find your data there? Are you repurposing something that existed for another reason? Or do you need to collect new data? Successful data collection practices are not a one-size-fits-all approach. Effective data collection practices are necessary for informed decision-making, enabling organizations and individuals to track progress and ultimately drive change. Once you're familiar with the data available to you, prepare a plan that describes what sources will be used and any steps required to acquire it. Here are some questions to consider when developing a data collection plan. If you're collecting new data, storage and protection from unauthorized access are two of the primary considerations that must be addressed in your data collection plan. There might be a cost associated with using third-party storage. What measures are you taking to keep it safe? Outline your storage protocols to ensure data security, emphasizing the importance of data integrity and availability. Consider backup mechanisms. If it's health information, it should be encrypted. These are all some considerations that we look at when developing a plan, not just for data storage and security, but also acquisition from the onset. So getting back to our definition of data literacy for a second. The second component I want to look at is managing data effectively. Now, this would normally include implementation of the data collection plan, but I'm going to focus on data quality. It's critical that we comprehend the data that's been collected, especially if it's been collected in many different forms and we're using it for different audiences' purposes. So as the dosing chart illustrated at the beginning of this webinar, a data analyst, program manager, and executive director will all have different needs. And managing data includes an essential skill of transforming, summarizing, and repurposing it for different audiences. Data quality is important because it looks at the condition of your data. Is it accurate, complete, up to date, and collected in a consistent or reliable manner? It's important that you're confident that the data you've collected is not of a poor quality, as this can lead to inaccurate analyses and potentially poor decisions. In the vast majority of cases, your computer programs will not tell you if your data is of poor quality. The phrase garbage in, garbage out exists for a reason. Quality assurance practices should also be applied to both the data producer and the data consumer. Accountability for data quality extends beyond the initial collection phase. Whether you're generating a data set or analyzing them, ensuring accuracy, reliability, and consistency is a shared responsibility. Anyone involved in data collection should identify and be able to identify data quality issues. These practices can serve as catalysts for elevating data literacy within an organization. This helps it become a business as usual practice rather than a sporadic effort where data quality is someone's responsibility. To implement quality assurance effectively, organizations often turn to data quality frameworks. These frameworks provide structured methodologies and guidelines and serve as a recommended starting point to determine what to focus on. By aligning with these frameworks, organizations can systematically address and enhance aspect of their data collection and data management that matters most to their specific needs. The CIHI Data Quality Framework is one such example, as is the Information Quality Framework, which is more recent. These are some practical practices that support data quality. Preventing data quality issues before they occur is ideal, as fixing data later is always more costly, if you can find the errors to begin with. Following data standards promotes consistency when capturing data. This is key for accurate analysis and meaningful insights. So if you're collecting information that has a data dictionary, ensure that you understand the rationale and response options associated with each element being collected. Data standards also serve as a common language, which can help to facilitate interoperability and exchange of information across systems down the road. Vendor specifications ensure that captured data aligns with industry standards. This helps organizations ensure that the data meets required criteria for data integrity and reliability. Ensure that data providers are adequately trained to capture and enter data. Proper training ensures that individuals responsible for data capture are equipped with the knowledge and skills to adhere to standards, minimizing errors and inconsistencies. And then validate data through periodic audits. Audits are a quality control mechanism. Emphasize that there's a dual purpose. One is ensuring data accuracy, but the other is to identify opportunities for ongoing education. And if it's required, emphasize that this education is not punitive, but it's a constructive way of enhancing the overall data literacy within an organization. It demonstrates an organizational commitment to continuous improvement and learning in the data management process. So the last topic I'm going to cover today is the 5 dimensions of data quality. This is first described in CIHI's 2009 Data Quality Framework. I'll also mention that in that reference, there's a data quality framework assessment tool that can be used to assess an organization's own data quality. It includes definitions, guiding questions, and examples. These dimensions, or some combination of them, are generally accepted as key components of data quality that appears across frameworks. The first dimension is accuracy. Accuracy is what most people think of when they think of data quality. Accurate data reflects the reality it was designed to measure. A good question to help decide if the data are accurate is to ask, is all of the appropriate data present? There's a few characteristics that can help understand this question. So the first is coverage. Do you know who should be submitting data? The second is non-response. Has all the information you were expecting been submitted, or is there incomplete information or missing data? And then the third is measurement error. You might have received complete information, but is it reporting what it's supposed to be reporting? The second dimension is timeliness. Timeliness refers primarily to how up-to-date the data is at the time it's released. We look at timeliness in terms of a gap between the end of a reference period and when it's available to use. So if you're undertaking a small quality improvement project with the data from the second quarter of 2023, but it won't be available until the second quarter of 2024, and then you're going to undertake your analysis, it could be over a year later. That delay might be okay, but it might not be relevant for our needs if too much time has passed for the size of the project. Timeliness is closely associated with relevance then, because if the delay is too great, it might not be usable. This can also become an issue when working with multiple databases that don't have the same timelines or release dates, or databases that are dependent on each other. It's common to expect some lag time to allow for quality control, especially with dealing with large volumes of data, but this needs to be kept in mind before considering it as your data source. The third dimension is comparability. This is defined as the extent to which data are consistent over time and use standard conventions, making them similar to other data over time. So comparability facilitates our ability to understand, interpret, and maintain data. This is especially important if the same data set accumulates over time. Ensuring that the same or similar populations are captured in the data also facilitates comparisons over a historical period. Databases that are comparable will use the same definitions, collect similar types of data, have potential for record linkage with other databases. This is more of a consideration when collecting new data, but if you know from the onset you're going to accumulate data as part of an ongoing process, it's important that it doesn't change too much so that it can't be compared down the road. The fourth dimension, usability, reflects the ease to which data may be understood and accessed. The purpose of the usability dimension is to identify problematic aspects of data as it relates to its ability to be interpreted. If data or other products are difficult to use, they can be rendered worthless, no matter how accurate, timely, comparable, or relevant they may be. Several factors may contribute to the usability of a data holdings data. In general, the number of limitations or exceptions associated with the data, the more difficult it will be to interpret. This increases the number of manual validations that need to occur, and it might require you to consult other resources for the purpose of interpretation. So it must be readily accessible. It must be user-friendly, and no matter how well documented it is, if users aren't aware of it, it can't be used. Now, this may seem like an obvious statement, but it reinforces that you may already be collecting information that's usable for your purposes, but hasn't come across your desk yet. Reviewing data sources and collection practices serves as a helpful reminder of what might already be there. Lastly, we look at relevance, which is the degree to which data meets the current and potential needs of users. Maintaining relevance requires staying connected with key users and stakeholders. This information will vary based on the work you're undertaking, but ensuring that data is accurate, timely, comparable, and usable, it's important the data continuously reflects the most important and pressing information needs. Now, the third component in the data literacy definition is evaluating data. This is where we introduce the use of technical skills. Here we are drawing on insights from what has been collected and summarized. This is where the importance of a data quality culture comes into view. Data that have been collected and presented can easily be dismissed or shelved if they're not used. An organization with a strong data culture will not allow this to happen, but instead will stress the importance of analyzing the data, drawing inferences from it, and then actively applying these findings with a quality improvement lens. Evaluating data is something that we already do in our day-to-day lives, and Noshiba gave an example of that at the beginning. It's not meant to be an inaccessible competency. The goal is to incorporate this type of thinking into decision-making that you probably already use. Using information to inform your work becomes second nature. Another example, if you've changed behavior based on your household's energy consumption when you receive the utility bill, you've used data to influence your decision. But I'm leaving you with a cliffhanger today because this component, as well as the fourth, will be covered in the next webinar. And the fourth component, applying data in a critical manner, requires us to examine the data that have been presented with a healthy skepticism, moving us beyond gut feelings or instincts about what we expect the data to say. It's a key skill towards developing a data-driven decision-making culture within an organization. And it also starts to get at the very important "so what" question, and how will we use this information? Applying data for a specific purpose is a great way to build your critical thinking skills, but that's a discussion for next time. I'm now going to turn the presentation over to my colleague, Aaron Carubba, who will talk about building the culture of data literacy at Wayside House of Hamilton. Aaron?
Thank you very much, Derek. So following Derek's discussion of these data literacy principles, I want to talk about my experience and our experience at Wayside House, applying and in some cases failing to apply these principles at our agency, hopefully with the goal of imparting some lessons that may be applicable to your own practice in your own agency. So I'll start with some background. I entered the Wayside program as a relatively knowledgeable data practitioner, but with little knowledge of quality improvement itself. So my challenge since I was hired last April has been to learn about QI and to integrate this knowledge into the program at large in a way that involves our staff and actively engages them and requires them as well. So I'm going to get into that. But first I will discuss a little bit about Wayside's background and history, just to give you some context. So we are a residential addictions treatment facility for men. We're located in downtown Hamilton. We have 24 beds, we have 25 staff, and we have 2 cats who are volunteers at the agency. Most of our staff are counselors. We have 3 managers, and we have 1 CEO, and we have 1 quality improvement staff. That's myself. So all this to say that Wayside is a small agency in feel, if not in reality. I know definitely smaller agencies exist. We all work very closely together, and we're familiar with each other's work. Maybe less so in my case since I was coming on as a new position, but even so, when it comes to communicating with counselors and managers at Wayside, often all it takes is sort of turning over your shoulder and shouting to the person in the next room or the person working behind you. So this context is a luxury and a burden that may be different from other agencies that are larger, that have more complicated QI staffing structures. So I wanted to just put that up at the top as a caveat, because it may impact some of the things that I talk about. Wayside was established in 1967, and the data don't go back that far, but they go back almost to like the turn of the millennium. So there's lots of data available, mostly through Catalyst, like the data management software that we use, and I'm sure lots of you use too. And the question really becomes, what to do with it, especially in my case, coming in with no specific QI experience. It's been a journey. There's been ups and downs and everything like that. So like I said, I started in April 2022. I've completed 1 quality improvement project so far through E-QIP, and we're in the process of completing another one. So I'll tell you a bit about those, but first I want to give you a bird's eye view of the areas of focus of this little talk. So I tried to lay these out to mirror the progress of a quality improvement project. So starting with identifying a problem, then figuring out how to measure it, then presenting some results after you generate them, training staff on how to understand and interpret and apply the results, and then talking a bit about, at the end, sustaining changes brought about by these results and building a culture of continuing this sort of iterative cycle. So I am going to discuss these areas of focus using two projects that we've mentioned, but I want to first talk about the data culture assessment tool. This is the shameless plug portion of the presentation. This is a very, very useful tool that E-QIP has generated. If you looked at those areas of focus and they sort of didn't give you anywhere clear to start, if you don't have really an idea of where your agency is at in terms of quality or data capacity, which is where we were at when we started, you're welcome, Laura, then this tool may be the one for you. Try filling it out. It has many different useful dimensions. For example, like data entry and training practices were very relevant to the things I'm going to discuss in this presentation. So have a look at it. It's also useful to fill out after a project is done, like I did, and I'll mention that at the end as well, to sort of give yourself a benchmark for how you're progressing through the journey towards improving data culture at your specific agency. So these are the projects that we've worked on when it comes to building data culture and literacy and just sort of improving service at Wayside, keeping in mind that's always the ultimate goal. The first, which we started last year, was on waitlist management. Very simple to explain, very relevant to every agency I can imagine. Clients have waited too long to come into Wayside. It severely impacts their chances of success. It's super, super crucial to make sure that they get into Wayside House as quickly as possible. The flip side of that, and the quality project that we're working on right now, is discharge rate, or more specifically, early discharge rate. So we want to explore the reasons why clients leave our program early, especially considering that our program can be up to 90 days long, or sometimes even cases longer than that, with an investment required from the client on such a larger scale. Exploring the reasons why people do leave early seems very important. So it's worth mentioning, in reference to what Noshiba said at the top of the talk, waitlist management, measuring the waitlist is a point of care measurement, and measuring the discharge rate is an organizational measurement. The way I understand this is that the wait times are something that's more client facing. So if a client calls up and says, how long can I expect to come in? A point of care measurement is something that you would directly deliver to the client. Discharge rates may be less so. They would impact client care indirectly. You wouldn't in most cases report that directly to a client. So it's a measurement that impacts the organization on a more general level. So, okay. We have people coming into the program. We have people going. It's relatively straightforward. I want to talk about how to describe these problems because it's sort of deceptively simple. So, like I said, I started in April of last year, and I was really excited for the waitlist to be the first project because in my mind, in my very sort of like quantitative mind, it seems like such a cut and dry thing to tackle. You know, how many days did somebody wait? There's really only one answer to that, or so I thought. And we had the experience of stumbling at the very first hurdle when I asked how long is the wait list, and the answer came back about 2 months, maybe. Sometimes it's shorter, sometimes it's longer. What I quickly discovered is that at Wayside we didn't have any sort of reproducible system of producing wait times. It was really a case-by-case anecdotal sort of thing. So to me, this is an example of how seemingly simple problems can really become tricky when you attempt to describe them or quantify them. This project, I thought it was going to be about reducing wait times, but very quickly it became about creating a system of measurement. So the question of identifying a problem also leads into the question of who is this a problem for? So naturally, it's a problem for the clients who want to access the service. But when it comes to staff at Wayside, it's more of a problem for the intake coordinator than it is for the clinical staff, for example. So I learned that pretty quickly when it came time to sort of learn more about how the waitlist functioned and how I could go about trying to get a measure of how long people were really waiting. It's not that clinical staff didn't want to know about the waitlist or weren't interested in having that information. It's more that their day-to-day function didn't really involve managing the waitlist. It was the intake coordinator, of which there's only one at Wayside, who was really the person to go to for this information. In the case of discharge management, which I'll discuss on the next slide a little bit, it was inverted. So the intake coordinator had less information about that, but the clinical staff had a lot of information about that because they handle client resistance and client ambivalence on a day-to-day basis. And these aspects of addiction and recovery are very closely related to discharges. So I wanted to say that when it comes to identifying problems, who you're asking about the problem seems really important. And that may sound like a truism, but it's something that I had to learn through experience. yeah, just because it's different employees have a different perspective of the work that's happening, even at an agency as small as Wayside. So, right, the problem initially identified wasn't the ultimate focus of the project. So we need an accurate way of measuring wait times. And I'll discuss that a little bit in a couple of slides, but I want to talk a little bit first about discharge management, which again, deceptively simple. So you may be familiar with the fishbone diagram, which I have here. The question that I posed to the clinical staff was, our discharge rate is too high. It's like 45% or something like that over the last year. Why do you think clients leave early? And when I sat down before I presented this to the clinical staff, I had my own ideas, mostly based around like client expectations and sort of these like more like drier, more systematic concerns. When I put it to the team, the floodgates open. They all had their own perspectives based on their individual interactions with clients and their experiences, how long they've been at the agency and everything like that. So this one problem of clients leaving early very quickly became many, many problems that touch on every aspect of the agency. It touches on the wait list. It touches on service delivery. It touches on transition planning, like client-client interaction, staff-client interaction. It really just blossomed into this very multifaceted set of concerns. And the question arises again, who is this a problem for? I guess I mentioned that before. It's a problem for the clients, of course, but it's mostly a problem for the clinical staff. So that's, when it comes to measuring these problems, those are the people that we want to go to for insight on what we should be measuring. So having talked a bit about the problem of the wait list and the problem of discharge management, we have a bit of a better idea of what these problems are, how to prioritize them. So now I want to talk about measuring them, the extent to which they exist, and how likely it could be that you could even measure these in the first place. So the first thing I want to say is that not all problems are equally quantifiable. I know Derek talked about this. Some problems are more measurable than others. Like I mentioned, like my initial intuition about the waitlist being easy to measure is true in a strict sense, more so than when it comes to something like the reasons why somebody leaves a program, or if you're looking at client satisfaction, which is I know is something that a lot of agencies measure pretty often. That's a very sort of squishy, subjective thing. And it's not to say that it's not worth measuring. It's just that you need to consider that it may be more difficult to measure that than something more concrete, like number of days on the wait list or number of people who discharged in a month. You also want to consider the process of data collection, how are data collected and by whom. In the case of the wait list, I'll talk about this on the next slide. It depends a lot on the systems that you're using and who's at the front of them and the priorities they had when it comes to collecting data. And then uncertainty is a very, very big concern as well, before and after the data are collected. So simple measures are the best because they're the least likely to be incorrect. They have fewer points of failure. For example, when it comes to discharge management, I guess I mentioned this already too. Discharge numbers are objective, but discharge reasons are subjective. So the goal would be to sort of combine both of those in some way to come up with a more complete picture of the problem that you have at hand. So we had a lot of trouble with uncertainty as far as wait times went, and I will use this slightly complicated diagram to explain that. This is our referral process map. The important thing to notice here is that after we received a referral, there was a bifurcation that took place, or a split. The intake coordinator had his own manual client list that he managed in a Word document that he worked from to schedule interviews and intakes and that sort of thing. Parallel to that was the catalyst assessment programs that we would open clients up in and then close them when they either expressed disinterest in the program or entered the program. So what we have here are two ways to measure wait times. We have the stuff that the intake coordinator tracked on his manual list, and we have the more automatically generated catalyst assessment programs. Like you open and close them, you compare the dates, and then that's some measure of wait times. So this enters into the comparability and usability dimensions, and we're asking about validity here as well. Which of these is more accurate? Which of these is actually capturing something that resembles the client wait experience? And that's an open question to this day for us at Wayside. There's pros and cons to each of these. One of them is more prone to error because it's kept by hand, but the other is more difficult to generate reports from because it exists in Catalyst. So my challenge, my opportunity, my job was to sort of explore the pros and cons of each of these, combine them as I could to come up with some relatively accurate measure of wait times and present that to the staff. So this impacts staff culture because they have different access to different aspects of the referral process. So the intake coordinator has his list and he knows a lot about the clients on the list. And a clinical staff member wouldn't necessarily have direct access to his list, but they would have access to Catalyst. So accessibility of information can impact how staff are perceiving the problems as well. So the goal is to use data to rectify the differences between these different sources and to determine some sort of consensus to work from. Like, to me, that quickly became the goal. It was the goal from day one, but it became very more urgent as time went on. Like, I wanted to come up with something that staff could use to communicate with clients on the wait list. So we did a lot of work to figure out what to measure and how to measure it. And we eventually managed to come up with some measurements. And the question next becomes what to do with them. And that leads into the question of presenting results and training staff on how to interpret them and understand them. So the first thing I want to say is that not all results are equally relevant. And this should be relatively obvious, but I think that it's important to mention that there's lots of things that you can collect and fewer things that you should really strive to integrate, like, or present to staff on a regular basis, because I know at Wayside that our clinical staff are very busy. And the last thing I would want to do is, if they have 100 things to do, I don't want the 101st thing they have to do is to understand like what a p-value is or how to interpret like a new type of chart or whatever. I want the data that they get to be as relevant to them as possible and as actionable as possible, like Derek mentioned sooner or earlier. So introducing data literacy concepts as they're needed seems important to me instead of mentioning them all at once. So this speaks a bit to my own background. So having had a bit more of an academic background, I find myself interested in results and data for their own sake. Like, I have an academic interest in, you know, the distribution of wait times, like what can we expect it to be, or like how to remove outliers, how to define an outlier in that kind of sense. Like these technical or specific considerations that are important, but less so than the really meat and potatoes aspect of, okay, what's the average? What do we have to do to reduce it? What's contributing to the number being high? That sort of thing. So in my own experience, I don't know if a lot of people can relate to this. There's been it's been a process of me of learning how to relate to the more frontline considerations of staff, especially in the context of addictions treatment. So yeah, what I wanted to say at the end of this slide is that results should be actionable. And this goes back to what we choose to measure. So if we made a good decision when we decided what we want to measure, the results should speak for themselves in terms of suggesting a course of action. So I want to illustrate this point with a couple of graphs. So in the grand tradition of the Goldilocks and the Three Bears, I'd like to discuss an example of a graph that is too much. So this is what I would describe as like an academic way to present data. So I mentioned the two wait lists earlier. They each have an average wait time. And some clients are present, or most clients are present on both lists. So in my mind, I said, well, let's make a scatter plot. Let's put all of the wait times from one client on one axis and all for the other wait list on the other axis. And then we'll have all these points. And we can look at like the distribution of wait lists comparing the two sources. And like these data are like, you could glean something from this, and it does tell you something, but it doesn't jump out at you. And it's a bit too overly technical or cute or specific. And there's no immediate action like suggested by a graph like this, beyond the fact that like maybe I have too much time on my hands when it comes to interpreting these waitlist times. So maybe we'll look at something like this. So comparing medians. So a lot simpler to understand. The result jumps out at you right away. The assessment wait time is higher than the manualist wait time. Very simple. Maybe too simple, but maybe not. Maybe this is all you want to communicate. Like maybe this is all I would want to communicate to the intake coordinator, is that it seems like your list produces a shorter estimate of wait time than the Catalyst does. Why do you think that is? Maybe you're taking people off too soon, or maybe we're leaving people open in Catalyst for too long. So there is more that you can get from a graph like this, I think, on an actionable basis. It tells you that there's a difference between the list, and it's easier to see, but it may not tell the whole story. There may be relevant questions that we could ask that aren't answered by a graph like this. For example, the one that jumps out to me is like, what is the longest time that somebody waited on one list or the other? Or what's the shortest time that somebody waited? And again, which one is more accurate? That's not really answered by a graph like this. Spoiler alert, I haven't been able to answer that question yet. But I'll show you one more bowl of porridge. This is the histogram. So this is a distribution of wait times. So I'll take a couple seconds just to explain this. You have different bins at the bottom. So the first one would be 0 days to 27 days. And about 40 clients waited that length of time in that bucket. And when you lay it out like this, it produces a distribution. And somewhere in the middle is the median. I guess right in the middle is the median. And what I did to create this chart is that I combined the two measures. So leaving aside the fact that I'm combining disparate data sources, there's probably all kinds of errors that are introduced in that process. And this isn't something that's like completely airtight, but I wanted to produce something that staff could work with, something that we could start to talk about. So I did some work on my own end, combining these two different sources. I took out some outliers, I compared them, I considered the pros and cons of each data source. And then I arrived at some sort of aggregate combined measure of wait times with a median of 98 days. So that right there to me suggests something. If you remember slides ago, I discussed the anecdotal wait time being delivered to prospective clients being 2 months. So right there we say 2 months, the data, this like sort of Frankensteinian combination of data suggests like 98 days. Why is that? Is it because we're overestimating? Is it because we're underestimating when we report to clients? This gives us things to discuss. And when in comparison to the medians, this distribution tells us more. It tells us how the data are arrayed around the median. So we have this long tail of outliers, and you can see like at the extreme end, the final bucket is like 243 to 270 days. Clients aren't waiting that long. By that point, like they've either moved on to another treatment agency, or they've decided not to come to Wayside, or they forgot to let us know that they're not coming. These are outliers, but they're pulling out the median, and they're impacting the average in a way that you wouldn't see if you just looked at the medians by themselves. So to me, this is actionable too. This suggests that of all of the waitlist data that we're collecting, some of it is not representative of the average client's experience. We might want to work on a way to eliminate these outliers when it comes to calculating a wait time, an actionable wait time. And the thing that I suggested that we're working on implementing is like a maximum wait time for the purposes of reporting. Like maybe after 3 months, we say like, that's the longest you could reasonably expect a client to wait. Not to say that if somebody called on day 91, we would have them start from 0, but just to say that for the purposes of reporting that there are these cases where individuals get left off for too long, or they don't respond to us, and they sort of drag out the median a little bit. Not that the median is the important thing in this situation anyway. The important thing is really considering the process of reporting these numbers to the clients and to the staff as well. So reporting them to the staff is what I'll discuss a bit in the next slide here. Mainly what I wanted to mention is that these data have suggested a course of action, and like it's produced discussion, it's thought-provoking, which is different from it being confusing or difficult. So if you think about the scatter plot, it provokes thought, but like in an overly technical way. Like you're thinking about, what is this? How do I understand this? I think that when you present data in the right way, it provokes thoughts like, what should we do with this? What does it mean for our clients? What does it mean for my everyday practice? So I think that like straddling that line between too complicated and complicated enough to suggest some sort of course of action is like, I'm still working through that, but this was a nice way to illustrate that at Wayside. So finally, I'll talk about sustaining change. I'll mention again the data culture assessment tool, which, as I mentioned, is very helpful for keeping track of how your agency is progressing in terms of data quality and data culture. So in our case, when it comes to waitlist management, We managed to improve the accessibility of our reports, and we managed to produce real-time reports of wait times. And we're also working towards allocating time towards data at the agency. And this has sort of just been a natural byproduct of me being around for like a year or longer and working as closely as we do. I try to report data to the clinical staff and to everybody really as often as I can. We have weekly case reviews. So the expectation has kind of become, what are you presenting this week? Like, what do you have to show us? And like, I find that, I don't know, it's nice. It's flattering, first of all, but second of all, like, I like that it's being worked into the process of the agency in general. So this is like what I mean when I say integrating reporting into the everyday routines of the agency. And then the idea of building like these self-sustaining systems, sort of a highfalutin way of just describing like, make your data collection process as straightforward as possible. After you've done the hard work of considering like what should we be measuring and how should we be measuring it, make sure you set it up so that it's really easy for you to do so. It's kind of a truism, but like I think that at least my tendency has always been to come up with the most robust, detailed systems, when in reality, I think the priority should be given to like systems that are easily reproducible and reliable and workable and easy to understand. So this is just like a chart that I use to keep track of the average wait time of clients from day to day on the wait list, and then the number of clients that are on the wait list from month to month, sorry. So it doesn't look like much maybe in this form, but it took a lot of work to get here. And I think that that's important to mention. Like, even if the end product is very sort of simple and straightforward, it doesn't mean that, you know, it didn't take a lot of work to produce it. What I want to say in terms of sustainability is that you can't hope to sustain things on your own, especially if your role is just data or quality specific. At a certain point, you have to hand off the results and the learnings to the team to execute. And that's why, like, I'm really grateful that I work at an agency like Wayside, because we have an awesome team. So I wanted to shamelessly shout them out if they're here. So thank you to them. Thank you to E-QIP for inviting me. And thank you to everybody for listening this morning. And I'm excited to answer some questions.
Thank you, Aaron. Thank you. Sorry, I'm moving the slides too fast. Thank you, Aaron. Oh, I think I'm gonna go one more forward. See if it stops here. Yep, great, stopped here. So Aaron, there was one question in the chat that I want to share with you. I may have missed this earlier on, but could you speak to remind us how and by whom this QI project was executed? And Ashley's looking for the number of team members, duration of the project, time commitment, how you carried out the project of this scope.
Okay, so I started in April. My CEO, Regan Anderson, has a member of AMHO, of course. It's a relationship with the E-QIP team. He suggested to them that we collaborate. And at that point, I had already sort of thought of the waitlist as a potential project. In terms of the team, I'm the only QI staff at Wayside, so I bore the brunt of the collecting the data and doing the fishbones and all that sort of stuff. As I mentioned, like, since our team is pretty small, we only have one intake coordinator. So he was my main point of contact for insight into the process. So he helped me generate the referral process map. And the clinical staff were helpful enough and gracious enough, I should say, to hear Michael, the intake coordinator, and I describe the process, ask questions about it. They looked at like the wait list times too. I showed them like a lot of histograms and things. So they participated. But it was largely myself who did most of the data collection and the analysis, with large assists from the intake coordinator and input from the rest of the team as well.
Thanks, Aaron. I'm going to ask Naveen to launch the poll, which is our evaluation questions, and we're going to keep going with questions in the meantime as well. And so, in terms of one of the questions,
I will enter.
Oh, sorry. Does somebody have a question that they want to ask in, like, using their voice? Yes? No? Sorry, I was just hearing. Maybe it's just my echo. So in your opinion, what mandatory fields in Catalyst are the most informative for actionable decision making? I'm going to pose that to Aaron and Derek because I know both use Catalyst.
our agency uses Catalyst, but I actually don't have a lot of oversight over the Catalyst usage here in my portfolio. So, yeah, I'm going to defer.
I would say, if you're looking at wait lists, like I mentioned, just running a report of because we have a program specifically for clients on the wait list. I'm not sure if your agency does too, but if you run a report of all the individuals that are in that program for a given time frame and look at when the program was open and when the program was closed, that can give you an estimate of wait times. I know that Catalyst has waitlist functionality, but it's very similar to the manual list that I said that our intake coordinator used, because you have to put people in it one by one, and you have to remember when to take them out and to register them into programs. So in terms of mandatory fields, I think that like program start and end date can be surprisingly helpful if you want to keep track of like how long clients have engaged with your programs. I know I'm doing that for the discharge management project that we're doing. That's mainly what I would say. Like those are surprisingly useful. It depends on the specifics of your agency. I know that you can run reports on like presenting problem substance and things like that. Those might be useful as well if you're trying to get like sort of demographic data about your clients.
Thanks, Aaron. Sean's asking, any thoughts on how to train a data collection team? At CAMH, we use people with lived experience as surveyors, and I'm always concerned I'm not giving them enough surveying training. I'm also wondering whether, if actually part of Sean's question is as well, how do we, as organizations, explain or share the value of good data collection, of accurate data collection with the people who are actually collecting data regularly, who are often the clinical staff. So I'm going to add that as part of the question for Sean. And again, open to both Derek and Aaron.
You know, it's interesting how many resources do exist generally around topics. So you know, there are some surveying fundamentals, and I don't think you know, applying the specific example of how surveyors at CAMH you know, are doing their work is that much different from general surveying practices. So it's funny how, you know, these things have been developed for other purposes and are readily available. And you know, other than some of the specifics around coaching to language, around specific purposes for a survey that's being done, a lot of those generalities do apply. And like anything, requires practice for the surveyors. The surveyors get better with time and with practice. And no, Shaba, I forgot the second part of your question while I was answering the first.
Just part of it is, so you're talking about surveying, so I think we're talking about like direct data collection. What about how do we support clinical staff who are collecting data that they may or may not be regularly using, and to kind of express the value of that data and and especially the importance of accuracy?
Yeah, I mean, I think sharing back, one, it has two purposes. The first is simply showing what the end result of your endeavors does. So we're sharing back what it's been collected for so that you can visualize the actual data. And then the second part is, of course, tying it to the work. You know, clinicians in our organization and generally, they want to see how the data informs something that can be done in their job and how it benefits the client. So getting beyond, you know, I think the Goldilocks analogy is a pretty good one. Not just how it's presented, but what can you do with that next to connect to your work, whether that's at a client level or at a program level, even within your own work.
Thanks, Derek. Aaron, anything to add?
I think Derek covered that one quite well.
Okay, so a question for you, Aaron. Have you investigated regional variation, age, diagnosis to see if there is a different split in wait time distribution? Also with Catalyst, do you have the data running in real time, downloading to your system daily?
So as far as I know, Catalyst doesn't have real-time functionality. If it does, then I'm very frustrated that I wasted a lot of time generating reports by myself. But what I would do is monthly, I would pull down the assessment program information and then use that to come up with our waitlist estimates. You can do it more regularly than that if you want. You can like pick the time frames for generating reports from Catalyst. As far as the first question goes, investigating regional variations in wait time distributions, that's all stuff that I'm really excited to start doing now. So if you asked me in April, I would have expected to have that all taken care of by this point, but that's before I realized that we had to come up with the system of measuring wait times first. Now that we have an actual more or less accurate way of measuring wait times, we can use those as comparators with other like demographic information, like you mentioned. So this was a foundational project. Now that we've done that, we can start to look at like those other interesting correlations.
Aaron, just in terms of asking a follow-up on that, like as your staff get familiar with the wait time reporting, are you finding them using the data when they're talking to clients?
Yes. So the answer definitely goes beyond just like about 2 months. Usually staff will use like the last reported instance of our wait time estimate. And it's also become the sort of thing where like it'll be like, well, let me ask Aaron what it is right now, that sort of thing. So I've become like a point of reference for stuff, which is, I think is very good too, since we work so closely together anyway.
Yeah.
So it definitely has impacted staff's like attitude towards the wait list. It seems like in general, even if we don't have like the up to the second number all the time, it just seems like something that's more accessible in general because it's not some anecdotal guess, that we're divining. It's more like we know it's somewhere around 90 days. So we can at least say that with some confidence.
That's great. Thanks, Aaron. So Sarah is saying, I'm picturing the wishbone graph and I find it cathartic. Oh, sorry, I lost the question. I find it cathartic seeing all the problems, challenges we hear about all the time in this field. But also I see how teams and organizations could easily get stuck at this stage, where the problem starts feeling too complex to tackle and not knowing where to focus. Any advice from the presenters on how to push through this stage of a QI project to keep moving on? And Sarah, if you need also support to push through the project, please ask for a consultation. You have 6 QI coaches who are ready and willing to offer you support through E-QIP. So you're also welcome to do that. But I will let Derek and Aaron answer the question as well. So pushing through a QI project when you get stuck.
I'll answer first, even though it was Aaron's fishbone diagram. Sorry. I think it's important to remember where in the quality improvement process you are. So there are other tools available depending on the stage that should be looked at in combination with the fishbone. But what I would say is if that exercise has illustrated other questions, it's not uncommon for your quality improvement question to change. Are you now at a point where maybe you've identified something that becomes the more appropriate, immediate quality improvement project? So you can deviate from that and start over, especially if it's overwhelming and you've identified something else that you think might be a precursor to the question you were looking at. So I think the idea of forward momentum is based on always looking at some aspect of it. Even if the project is changing, it's still being a participant in the project and not just scrapping it because it seems overwhelming, even if that means scaling it back or taking a different a diversion at that point.
Aaron, anything to add?
Yeah, I absolutely agree with that. I think there's also an aspect of pragmatism when it comes to these sorts of things. So the aspect of the problem that contributes the most may not be the one that you have the most control over. So if we're talking about wait times, if we have clients that are just generally unresponsive given like the nature of addiction and recovery, at a certain point, that's an unchangeable like sort of bedrock assumption of the work that we do. So you would naturally sort of turn towards things that you can work towards improving more like realistically, like I said, but there's degrees of that as well. So I think that there's like the concept of like quick wins versus wins that take more effort. So that may be a nice way of looking at it. Like how much does this contribute versus how easy is it to affect? I think that might be a useful metric for you. Yeah, that's what I would say. Trying to figure out which of the problems contributes the most and then which of them, Pareto chart, you got it. Talking around that more or less, but yeah, that's what you would want to do. Figure out which ones contribute the most and then focus your efforts on those first.
Thanks, Erin. I'm going to make this the last question. I think it's a good way to go out. What tips would you give to someone new to working with and understanding data in terms of understanding if they have the right data? And either of you can answer.
The right data. I guess, to find out if you have the right data or not, it would depend if it's useful for what you want to use it for. I know that sounds very straightforward and simple too, but I think the rightness of it depends on what you want to use it for. You wouldn't use discharge data to track like the wait list, for example, that sort of thing. So I think understanding where the data come from and what they're actually measuring, and then tailoring like what you want to do with it based on that, because you can't stretch data too far. You can't make inferences on data if it's not if it doesn't cover that. So that's, I guess, what I would say. Yeah, data definitions are important.
I'd add, recognize that the right data can be iterative. So it's not inappropriate. It's probably recommended to check with stakeholders along the way, both the people who are contributing to the data, but also data experts, other organization colleagues who are going to be affected by whatever question you're trying to answer. I think that's probably the starting point, but that's a tricky one.
And I'm just going to add, I think like the data you have is always a good starting point, right? You may not know whether it's the right data. It may end up generating questions. I think people look at data as if it's giving you an answer. And I would actually encourage people to look at data as if it's posing a question. So take your data, prepare it. Like you can see the number of different ways Aaron tried preparing the data, and it told him something different each time. And it tells your audience, as Derek was saying, something different each time. And so play with your data. Like anyone who knows me knows I love data, and I would say spend as much time as you can just trying to fiddle with it, try presenting it different ways, try looking at it, stratifying it different ways, and think about what are the different messages, and work with your organization, work with the frontline staff, get people excited about your data, and I think that's one of the ways that you start generating questions out of it as well. So Sean is reminding everyone, co-design your project with patients and clients. It'll give you insights. And Dara is identifying exploratory analysis can be a good step as well. And Lucy has reminded me that the consultations also can help you with this. And with that, I'm going to turn it back to Laura, who is going to take us out the rest of the way.
It's great. Thank you so much, Noshaba, Derek, and Aaron. It's been a really engaging session. And with that, we are happy to announce that we have our second in the series scheduled for February the 1st at 1 o'clock in the afternoon. And at this webinar, we will have guest presentations from both Derek, again, coming to us to share his teaser cliffhanger information that he was holding back on and sharing with us. So we will see that again on February 1st. And we'll continue to look at data literacy and dive a bit deeper into the world of data management and focusing on collecting data to elevate and build on our data literacy skills. We'll also have Dr. Laura Mills of Pine River Institute share practical use of measurement-based care. So if you we'll be sending this slide deck out, which will have the registration link included in there. I will also want to highlight that we have our virtual conference coming up. So this is a save the date for April the 23rd. It is a QI Innovations Conference, and the topic or the title of this conference is Building a Culture of Quality. So we heard from Aaron a bit about that today. And this conference is delivered in partnership by E-QIP, the Knowledge Institute on Child and Youth Mental Health and Addictions, and Ontario Health, flagging that we are accepting abstracts until the end of February, or until February 2nd. And our registration links for this will be registered soon. We had over 1,000 people register last year. And you can also follow us on our social media on LinkedIn for updates and registration opening day. E-QIP governance and leadership training. So this specialized training is tailored for your senior leaders and your board of directors. And in this type of training, we will cover the essentials, so a broad view of QI and the power of data-driven decisions and how these align with your organizational priorities. It will focus on pivotal role of your senior leaders and how that plays into fostering a robust quality culture within your organization. It's also worth noting that our training is not a one-size-fits-all. So we meet organizations where they're at, and we'll customize it based on your specific objectives and where you're currently standing in terms of your QI culture and performance management. And your leadership team will be, at the end of this, well equipped to drive quality improvement and instill a culture of excellence within your quality improvement portfolios. And wanting to let you know that we are booking into 2024. As Lucy mentioned in the chat, and we've mentioned a couple of times throughout this presentation, please engage with us through requesting a consultation with the links that have been posted in the chat. And we also have our Ideas Online learning, and this has a link to register as well. So this takes you through a self-guided curriculum based on the model for improvement and incorporates a variety of learning tools for this sector. And it's about 8 to 12 hours to complete. It's absolutely free and super easy to register and enroll. So please take that in if you're interested. So a big thank you again to all of you for attending today. Your active and engaged participation and your insightful questions made this session really lovely. And we really appreciate your commitment to elevating your data literacy skills. So keep unlocking that power in your data work, and we look forward to seeing you in February.